Well done. I'm impressed to see so many people here on such a beautiful day outside. I had to drag myself away from the garden and I just got here in time, but there we go. So I'm going to talk about what we get up to in oncology after patients have had surgery for their thyroid cancer. So the things that I'm particularly planning to cover are radioactive iodine, which is obviously the mainstay of the treatment that we give. I'll say a little bit about external beam radiotherapy, touch on chemotherapy, which essentially we don't really use for thyroid cancer, and then just finish by saying a little bit about some of the new targeted agents that are coming along and of benefit to a very small number of the patients that we see. I'm very happy to be stopped and ask questions as we go along, so please do just stick a hand up if you want to ask anything. So, radioactive iodine, why is it such a good treatment for thyroid cancer? So, well, thyroid cells are almost unique in having this pump known as the sodium iodide symporter, which pumps iodine into the cells because it's required to make thyroid hormones. So really, one of the only other tissues in the body that does have the symporter is salivary tissue, and that accounts for one of the potential side effects of radioiodine. We do see some potential damage to the salivary glands, but otherwise, it's a very targeted treatment, so that makes it very useful. The particular isotope that we tend to use is I131, and that's helpful because it has two sorts of emissions. It emits beta particles, which are high energy but very short distance energy depositors. So that's very good for cell kill. So it's the beta particles that get into, when the iodine gets into the cells, kill any residual thyroid cells off. But I131 also emits gamma rays, and that's quite useful because they're more penetrating, they get outside of the body, and that allows us to image to see where the iodine has gone. So it's useful diagnostically as well. And the other thing that's very handy about I131 is that it has a relatively short half-life of about 8 days. So that's long enough for it to be around to do some work killing off cells, but not so long that we have very problematic radiation protection issues with patients remaining radioactive for long periods of time. So it's a convenient isotope to use. So why do we use radioactive iodine? So in the majority of patients with essentially relatively low-risk disease, we're giving what we call ablation therapy. And there are a number of potential benefits to having the iodine. So it's possible a small number of these patients will have previously undetected metastatic disease, and we know the iodine can treat that. And in some circumstances, that can be curative. So particularly in younger patients with miliary lung metastases, we know many of them are cured with radioactive iodine. More commonly, though, what we're probably looking at is destroying residual microscopic disease in the neck, trying to reduce the risk of local recurrence, so a sort of adjuvant treatment. But what's also been cited in the past as being useful is actually remnant ablation. So as you'll be aware, there's always a bit of normal thyroid remnant. And in the past, it's been argued there is some value in completely getting rid of that, ablating that, because that then increases the sensitivity of thyroglobulin as a tumour marker. We would hope thyroglobulin would become undetectable after ablation. Therefore, if it starts to rise, it's a very sensitive marker for recurrent disease. So what are the indications for ablation? Which patients should we treat? So this is becoming increasingly contentious, and to date there's really no reliable randomized controlled trial evidence available. So what we know is all based essentially on big retrospective series, often single center series. Guidelines have changed. So the BTA, the British Thyroid Association, published guidelines on the management of thyroid cancer first back in 2002. And at that stage, it was really recommended that most patients with differentiated thyroid cancer tumours greater than 1 to 1.5 centimetres should just have total thyroidectomy and radioiodine, and it was just a blanket recommendation. The most recent iteration of those guidelines in 2014 really started to question the benefit of this approach, particularly in lower risk patients. And one of the main drivers for that was really concern about second malignancy rate. So we know many of these low risk thyroid cancer patients have a 99% chance of cure from their thyroid cancer. What we don't want to do is give them another cancer later in life, which may prove fatal. So we really started to question who is it that we really do need to treat. So in the 2014 guidelines, there were 3 categories of patients. So the first identified were those that the guidelines were quite clear there was no reason to give radioiodine. So that includes patients who have tumours under a centimetre, either unifocal or multifocal, low risk histology, so classical papillary, follicular variant papillary, or minimally invasive follicular cancers, no evidence of vascular invasion, and no invasion of the thyroid capsule. So if all of those criteria are met, you don't need to give iodine, definitely. There's then the group that the guidelines recommend we definitely need to treat, and size of tumour does seem to be particularly important in thyroid cancer. So tumours over 4 centimetres we know do carry a worse prognosis, and it was advised that those patients should have ablation. Any tumour with gross extrathyroidal extension, and of course if there's metastatic disease, then the iodine is a treatment for that. But then this third group are the uncertain indication for iodine, and the reality is actually the majority of patients that we see coming through our MDT fall into this uncertain group, and it's difficult. So there's not good evidence to justify either way. So this would include where we know there's extension of the tumour beyond the thyroid capsule, but there's been a complete resection, widely invasive follicular cancers, if there are unfavourable cell types, so tall cell variant, for example, if there are lots of lymph nodes involved in papillary cancer, and we just really don't know what the value of iodine is here, and that the guidelines introduce this concept of individualised decision making, which basically means you have a discussion with the patient saying, we don't really know, we need to think about your individual circumstances and work out what's best for you. And those circumstances include things like, so as you know, often these patients are young women, and sometimes wanting to extend their families, and in those sort of situations you may well say, well, we're going to have to delay that if you have radioactive iodine, so maybe in your case we'll leave it. So lots of other factors start to come into play. So for the patients that we decide are going to have radioiodine, there's quite a lot of careful preparation needs to be put in place before they have their treatment. So it's really important that patients understand what they're letting themselves in for before the treatment, particularly because of the radiation protection issue. So these patients are radioactive for 2 or 3 weeks after the treatment. And again, particularly for young women with young children, that has potentially quite serious consequences. They need to avoid close contact with the children. For women with toddlers in particular, that often means being away from home. So they need time to plan support for that. We need to avoid loading the patient with lots of iodine before they have radioactive iodine, because we know that can block the I131 getting into thyroid cells at the time of treatment. So we need to be sure the patients are off any medications containing iodine, so that the most commonly cited example of that is amiodarone. We like to avoid giving iodinated CT contrast, ideally for 2 months before the treatment. And we advise patients to observe a low iodine diet for 2 weeks before they come in for their treatment. So this involves particularly avoiding seafood, and dairy products can be quite rich in iodine as well. For iodine ablation to be successful, we need TSH levels to be high, because TSH drives iodine into thyroid cells via the symporter. So the traditional way of achieving this was to take patients off their thyroid hormone replacement. The pituitary would then obviously go into overdrive, make lots of TSH, and the levels went up. The patient also felt terrible. So these days we now have recombinant preparation of human TSH, which we can give as an injection for 2 days before the treatment, and most UK centres now use that instead. We don't do any routine pre-treatment imaging, we just give iodine treatment. Really critical, particularly in young women, that we do a pregnancy test, because it would be a disaster to give radioactive iodine to somebody who's pregnant. And we need to advise that patients stop breastfeeding at least 8 weeks before the treatment. The main reason for that is that the lactating breast actually expresses some sodium iodide symporter, so you can see breast uptake in the lactating breast. And in fact, I inherited a patient when I started in Sheffield who had just had treatment, had not observed the advice that she'd been given, and on her post-therapy scan there was really quite significant uptake in both breasts. We calculated she'd had about a gray of radiation delivered to her breasts, which then introduces concern about risk of breast cancer. So as I've mentioned, there are some radiation protection issues. Patients need to be assessed before they go home to make sure the levels have got down to what's considered safe. Legislation has changed around this recently, and there is now room for a bit more individualised risk assessment. So, for example, if you've got an elderly lady going home to be by herself, we're less worried about that than a young woman who's going back to be with young children and with caring responsibilities. We need to, so there is advice that needs to be given about pregnancy following treatment. So there is, with routine ablation treatment, there is no risk to fertility in the longer term, but we do recommend that women should defer attempting conception for 6 months after the treatment. And there is a reported increased risk of spontaneous miscarriage for up to a year, and men are avoided to take contraceptive precautions for 4 months. So in terms of the side effects, in the past, the biggest problem was the symptoms of hypothyroidism from thyroid hormone withdrawal, but that thankfully is gone. So beyond that, the side effects are fairly minimal, a bit of a funny taste in the mouth, often mild nausea, neck swelling, discomfort. And then in the longer term, the main concerns are around salivary gland toxicity, although that's relatively rare with the doses we use for ablation, and then this lifetime increased risk of second malignancy that I mentioned. So there has been some research in this area to help us refine the treatments. So the first trial really that got off the ground in the UK in thyroid cancer was the HighLow Trial, which was examining whether we could get away with giving a lower activity of radioiodine but still achieve the same success rate. The idea being that the lower level of radiation we expose patients to, the safer the treatment's likely to be. The study also examined whether using recombinant TSH was as good as thyroid hormone withdrawal for preparing patients for treatment. So this study, the primary endpoint was actually defined as ablation success rate. So that was a short-term endpoint, 6 months after the treatment, and that was defined as the thyroglobulin becoming undetectable and a radioiodine scan being clear. And so this trial was first reported in the New England Journal back in 2012, and it met the primary endpoint. So it showed that the lower dose of radioiodine and using recombinant TSH were non-inferior to the higher dose of radioiodine and the traditional thyroid hormone withdrawal. There's been a more recent publication with longer-term follow-up in this study, so we now have 6.5 years median follow-up for the patients who were in the study, and that's reassuringly so shown that that ablation success rate is also mirrored in no increase in recurrence rates for these patients. We've got some slides to show that. So in terms of ablation success rate, it was equivalent in all of the arms, non-inferior in the experimental arms. So we've really adopted the lower dose and recombinant TSH routinely. And then this just shows the risk of recurrence, comparing standard 3.7 gigabecquerels and thyroid hormone withdrawal, so the old standard treatment, with the new standard of 1.1 gigabecquerels with Thyrogen. And essentially there is no difference in recurrence rate. And you'll see recurrence rate are reassuringly low. So at 5 years, the recurrence rate is only about 5% in this group of patients. And this is local recurrence, which is almost always salvageable anyway. So I think this slide again just summarizes those findings. And one of the huge advantages of giving the lower dose of iodine is that we can now give this treatment on a daycase basis. So this is our practice in Sheffield now. Patients don't have to come and stay in isolation on the ward. They just come for the day, have the iodine capsule in the morning. We encourage them to drink lots of water because free iodine is cleared in the urine. And by mid-afternoon, they're usually safe to go home. And that's dramatically improved the patient experience with this treatment. So in terms of follow-up after radioiodine, we routinely do a SPECT CT scan after the treatment. What we most commonly see on that is uptake in the thyroid bed. My colleagues in nuclear medicine then guess the surgeon. But also, so we do a whole body scan to check whether there's any evidence of distant metastatic disease, which is iodine avid, although we very rarely see that. We then have this concept with the ongoing follow-up of what we call dynamic risk stratification. So we know for these low-risk patients, or patients who may have had slightly higher risk pathological features at their surgery, if they have an excellent response to radioiodine in that at 9 to 12 months an ultrasound scan is clear and the stimulated thyroglobulin is undetectable, then we can re-stratify them as being at very low risk of recurrence. And that has implications for the way that we follow these patients up. So there's a UK group at the moment actually writing some guidelines suggesting that for patients who've had an excellent response, they no longer need to be followed up for life, as has been historically the practice. And also for those excellent response patients, we wouldn't continue TSH suppression. We consider that unnecessary. So the other trial that's just been worth being aware of, so this study is still recruiting, although it's very nearly completed. In fact, it has hit its target number of patients. So this is the next step on from HighLow, examining can we really avoid giving iodine altogether for some of these low-risk patients. So low risk is defined as up to T3 by evidence of extrathyroidal extension. So T3A patients, so greater than 4 centimetres, are not included because they're considered to be at higher risk. Patients can have M1A, so central compartment nodal disease, but do have to have an R0 resection. And patients are randomised between having the new standard low-dose radioiodine with thyrogen versus no radioiodine, and then have very careful follow-up with annual ultrasound to look for evidence of recurrence. And the primary endpoint for this study will be local recurrence. So we await the results of that study with some interest. As I say, the recruitment is due to finish it towards the end of this year. There's going to need to be at least 5 years follow-up before we really have anything meaningful to say. But I think increasingly the suspicion is that this is going to justify us treating fewer patients in the future. So just to say a few words about using radioiodine for metastatic disease. So the most common sites of metastatic disease in thyroid cancer are really lung and bone. It's relatively rare to see patients with metastatic disease, probably only 5 to 10% of patients fall into this category. And around 50% of them do have significant iodine uptake, and in those instances radioiodine can control disease for significant periods of time, many years often. I've already said after treatment for lung metastases that can be curative. Bone metastases are not generally cured by radioiodine but can be controlled for many years. And the way we give the treatment is exactly the same procedure as when we're giving ablation treatment. We just tend to use a higher activity, so typically 5.5 gigabecquerels. We do a SPECT CT scan after therapy, and that very nicely shows whether the treatment's likely to be successful by demonstrating where the iodine has gone. And increasingly, we're able to undertake dosimetric measures to work out what absorbed dose of radiation has gone into those lesions, which we're hoping may predict for benefit from the treatment. So just to say something very briefly about external beam radiotherapy, I think the main thing to say is that it has a limited role in differentiated thyroid cancer. The times when we might consider it are when there is gross tumour invasion of adjacent organs, the esophagus, trachea, and when the surgeon is concerned that there is significant microscopic, or certainly if there's significant macroscopic residual disease, particularly if the patient has then had radioiodine therapy and there's been not very much uptake in that area. So my practice would always be to give radioiodine first, because if the disease is avid for iodine, you're likely to deliver much higher doses of radiation using that. But if the disease doesn't concentrate iodine, then we would give external beam radiotherapy. Also, patients with extensive PT4 disease and older patients we worry about more as well. The reason we're reticent about giving external beam radiotherapy is these patients will live for years even with more advanced disease, and the late effects can be horrible. So we don't perhaps see those so often in squamous cancer of the head and neck because those patients often don't survive. But in thyroid cancer, we have a collection of patients in our clinic who have had external beam radiotherapy in the past and have the most horrible late effects: brachial plexus palsies, skin breakdown, esophageal narrowing. Every time I see these people, it just reminds me why we avoid doing this unless we absolutely have to. The standard of care would now be to use IMRT. Having said all of that, in patients with metastatic disease, there is definitely a role for palliative radiotherapy, for example, for the treatment of painful bone metastases. That can often be very helpful. That's just to show a typical sort of IMRT plan. And one of the challenges of treating thyroid cancer with external beam radiotherapy in the past was the target volume sat in this sort of horseshoe shape around the spinal cord, which traditionally made it very difficult to plan the treatment without causing cord toxicity. But now we have more sophisticated IMRT capability, it's much easier to do that. So what I've said so far applies to the vast majority of patients who have iodine-avid disease and an excellent prognosis. There remains this small proportion, so about 5% of patients who either have from the start or develop iodine refractory disease, and we know these patients unfortunately carry a very poor prognosis. Without treatment, survival beyond 3 years is rare, and until very recently we had really very little to offer these patients. Chemotherapy really didn't work, so for lack of anything else to do, oncologists used to give these patients chemotherapy with drugs like doxorubicin, but the response rates were very low, and those responses, when they did happen, were very short-lived. So really a questionable benefit, and that's quite a toxic treatment to give somebody if it doesn't work very well. What we have now are the multi-targeted tyrosine kinase inhibitors. So this now goes back 5 or 6 years. These trials are reported. So 2 drugs are now licensed and NICE approved for use in the setting of progressive iodine refractory thyroid cancer. So the DECISION trial showed the benefit of sorafenib in extending progression-free survival, and the SELECT trial showed even more impressive results for a drug called lenvatinib. The problem with these drugs is that although they do control the disease very nicely, and lenvatinib in particular has quite a high response rate, so about 65% of patients get an objective radiological response, the problem is that they come with quite significant side effects. So they cause skin toxicity. In particular, they can cause a thing called hand-foot syndrome, where the palms of your hands and soles of your feet can blister and peel, and that can be really debilitating. They tend to cause diarrhea. They cause fatigue and weight loss, and particularly with lenvatinib, hypertension can be an issue, and it needs quite aggressive control of the blood pressure. So it's not without its problems, and we save these drugs for when patients have progressive disease that we're concerned is about to become symptomatic. We wouldn't start this on just anybody with small volume lung metastases, for example. But the drugs are now NICE approved and available to us. Just to touch on some of the other more interesting scientific developments, so understanding more about the biology of iodine refractory disease, we know that the reason thyroid cancer becomes refractory, or one of the reasons, is that the MAP kinase cell signaling pathway becomes switched off in some of these cells, and that switches off NIS expression. So we've recently been undertaking a study using this drug selumetinib, which is a MEK inhibitor, so it switches off signaling in this pathway to increase iodine uptake in refractory lesions. So this has been running in a number of centres around the UK, and we've got some very interesting results from that. The advantage of this approach is that it's a short course, so we give the selumetinib just for 4 weeks, and then if increased iodine uptake is demonstrated, then the patients have further radioiodine as a one-off treatment. They don't have to continuously take drugs as you do with the tyrosine kinase inhibitors, and we're hoping this may lead to a further period of disease control without the side effects of treatment. So finally, just to say, in patients with advanced disease, there are other things that we consider. Often we would consider the role of palliative surgery, if there's a good reason to do that, particularly for central compartment disease that may cause critical problems. Often we consider embolization. Metastatic disease is often very vascular. Embolization can be a very effective way of helping with pain and controlling disease. Ethanol injections are sometimes used. And I think it's important to say that specialist palliative care input can be really critical. So the thing with thyroid cancer is the vast majority of patients have an excellent prognosis and going to do fine, but when it goes bad, it can go really horribly badly wrong with a lot of very difficult symptoms to manage, and those patients do need a lot of support. So that was everything I had to say.